All right, class, welcome in. So today we're going to be talking about neurodevelopmental disorders. The diagnosis that we're focusing on, or diagnoses rather, are ADHD and autism. But we do go have an overview of the chapter, and we also are going to touch base on the specific criteria for ADHD and autism. We're going to touch base on the different assessments and the different treatments that we're going to see when you're actually working with individuals who may happen to have ADHD and autism, or that's the primary concern. Um, we also touch base on some identities toward the end of what kind of identities are also being seen with people who have autism and ADHD, and what are the vulnerabilities. All right, y'all. I'm excited to get into this one, and let me know if you have any questions. I look forward to seeing you in class next week. And yeah, so this one may be a little bit long. If I can't split this up into two myself, please, watch it in different parts. This one is a long one, so please, um, break it up, take your notes. At some points, I do ask you to pull out your DSM, so please go ahead and get that ready. That's toward the beginning because that's where the criteria is. All right, y'all. Look forward to seeing you on Thursday. Right here is the DSM overview. So here you have a lot of different diagnoses that are going to be a part of the neurodivergence chapter. So you have intellectual disability, intellectual developmental disorder, communication disorders, and these are all the different types that fall underneath this. The autism spectrum disorder, attention deficit hyperactivity disorder, underneath that's other specified. Specific learning disorders, these are the different types. So other motor disorders, stereotypic movement disorder, tic disorder, and then other neurodevelopmental disorders. This is just a very basic overview, and I want you to keep in mind these and kind of anchor yourself with this as we talk about this, go through the slides, because it's a lot. But being able to anchor yourself to this and remembering the basics can be helpful when trying to remember, um, throughout this slide and beyond, like actually working with people who have autism or ADHD. Maybe you're going to be less trained in autism because of the specialty need of diagnosing, but it's still relevant, especially if you're working with people and they happen to have autism, or you're wanting to, educate someone about it. Um, so the quote here from the DSM that to keep in mind is neurodevelopmental disorders are a group of conditions with onset of developmental period, and that's the reason why we see it diagnosed mainly with children, but these diagnoses may have been missed. So that's not to say that it's limited to children. Autism is generally uh, a set of symptoms that may hinder, person's social and sensory problems. So ADHD, written out here, attention deficit hyperactivity disorder, and affects self-control, focus, organization. These are just very basics of what we're going to get into. Here we have the major criteria for autism spectrum disorder. So we have deficits in social communication, social interactions across multiple contexts as manifest by the um, cur following currently or by history. Examples are elusive but not exhaustive, and then see below. So this is deficits in social emotional reciprocity, deficits in nonverbal communication, deficits in developing and maintaining and understanding relationships. So here we have the social background of what meets a criteria for autism spectrum disorder. Now, if we notice, there's going to be different perspectives or cultural dynamics that meet this criteria. So that is why it's important to have multiple different aspects of meeting this criteria or additional training to be able to diagnose this autism. We're going to specify there's current severity. Severity is based on social communication impairments, restriction, and repetitive patterns behavior. This is from the DSM. All right, major criteria again is criteria B. So this is the restrictive repetitive behaviors, patterns of behavior. So this could be with interest, activities manifested by at least two of the following. This is current or history, examples elusive but not exhaustive. So the examples are stereotyped or repetitive motor movements, use of objects or speech. Simple stereotypes, lining up toys, flipping objects, echolalia, which is when somebody repeats the other person's language, idiosyncratic phrases, um, inconsistent or sameness, inflexible adherence to routines, highly restricted fixated interests that are abnormal and intensely or focused. Hyper or hyperactivity, sensory input, or unusual interest in sensory aspects of environment. So this could be indifference to pain, temperature, adverse response to specific sound, texture, and then specify the severity based on the communication impairments or the repetitive pattern behaviors. So something that is said about autism is if you've met one person with autism, then you've met one person with autism. And the reason why that is a saying is because the criteria is so individualized to each person that it's not going to show up, these criteria are not going to show up the same way in any two people. All right, criteria C, D, E. These symptoms must be present early developmental period, but may not become fully manifest until social demands exceed the limit. So this is why we're maybe seeing, okay, we're seeing some social context within the school. Some diagnoses would be later on. Criteria D is symptoms causes clinically significant impairment in social, occupational, or other important areas of current functioning. So the point of a diagnosis is to be able to gain support or understand something about a person. And we'll get more into that as we talk about identity and how people relate to the diagnosis. Criteria E, these disturbances are not better explained by intellectual disability, intellectual developmental disorder, or global developmental delay. There could be comorbid, comorbid experience, but it's important not to label autism spectrum disorder when we may be missing another diagnosis or something's being labeled as a because you can meet the other criteria, in A through A and B criteria with the intellectual disorder as well. With the major criteria for autism spectrum disorder comes the specifications as well. So here we're going to be able to specify, is there with or without accompanying intellectual impairment? With or without accompanying language impairment? So coding note, using additional coding to identify the associated medical or genetic condition associated with another neurodevelopmental or mental behavioral disorder. Coding note, so these are just specifications from the DSM. With catatonia associated with a known medical or genetic condition or environmental factor. So these are some things that are important to note or gain insight. As clinicians, initially, you're going to probably want to just gain insight about a person's diagnosis. And then if you are, gain the training to diagnose autism, then you're going to want to learn more about these to be able to apply the diagnosis or work alongside with it. Here we have the severity level of autism spectrum disorder, and it speaks to the different needs that somebody is going to be experiencing. And this is a general overview, and I believe that this becomes more and more relevant as people need more and more support. That is not to say that an individual always needs support. When meeting the criteria for autism spectrum disorder, but it looks like different types of needs. So for example, level 3 requirements for very substantial support. This goes to the diagnosis with social communication and restrictive repetitive behavior. So for example, someone may be severely nonverbal, they may not know any social cues or respond to others at all. They may have limited initiation and social interaction. For the restricted repetitive behaviors, it may look like very inflexible of behavior, extreme difficulty coping with change, difficulty focusing on change as well. Level 2, we're going to be saying requires substantial support rather than very substantial. Here we have marked deficits without support, limited initiation of social interactions. They speak simple sentences but are limited to special interest and odd nonverbal communication. For restricted repetitive behaviors, you're going to be saying appear frequently. The inflexible behaviors appear frequently, and they interfere with functioning and are obvious to the casual observer. Level 1, we're going to be requiring support rather than substantial support. So here we have noticeable impairments, difficulty initiating social interactions, able to speak in full sentences, but to and fro conversation fails. So that back and forth reciprocity fails. In one or more contexts, for the restricted repetitive behaviors, it's difficulty switching between tasks, difficulty planning, organizing, hamper independence. So again, every person is going to be experiencing things as that person does. And because the diagnosis is incredibly unique for each person, on one day it may be extremely difficult to cope with change, and on another day it may be, okay, this is difficult, but it's not extremely difficult. Here we have this example of clarity is kindness, sense of communication with somebody who has autism spectrum disorder. So here I'm going to try to play this video and we're going to talk about it.
My birthday is April 2nd, 1997. Hey, do you have to do that right here, right now? Yeah, I made an appointment.
Clarity is kindness.
I'm sorry. I'm feeling really distracted. Do you mind going outside? Oh, yeah, sure. My last name is... Hey, come on. You know what time it is? It's 2:15.
Clarity is kindness.
Put your stuff down. Stand up. Got a meeting to go to. Oh, okay. Hey. Yeah. Did you forget to respond to that email? No, I saw it. I was just gonna do it later.
Clarity is kindness.
Okay. Do you mind? Can you respond to it by the end of the day? Oh, yeah. Please? That's fine. No problem. Thank you. Clarity is kindness means saying exactly what you mean. Not hinting, not expecting someone to read between the lines. If autism acceptance is going to be more than just a slogan, it has to show up in how we communicate. Click the link in my profile to grab your shirt and make this practice a part of how you engage every day. These shirts are printed by autistic adults, and proceeds go to supporting their wages and programs at Project Hope. To make an appointment for my...
All right. So here we've seen this is acting, right? For this short, and you have the links here if you want to go ahead and check those out on her page. If you've already seen her, she has lots of conversations about what how autism is observed and how someone can support. And I believe that because it's a social interaction part of the diagnosis, there is a call for other people to also learn the skills. So here we have the examples of clarifying, okay, what is it actually that I'm needing? And that's maybe a cultural shift for people if they haven't dealt with it before. But I find that people are motivated to do so because it gains clarification and creates connection with individuals, especially their family members or children who are diagnosed with autism. So here we have an example of another quote here that says, too different to fit in, too normal to be different.
Adults, and proceeds
Now
go to
here I have
supporting
the
their
shirt
wages and
as
programs
well.
at Project Hope. To make an appointment for myself.
And so this example, this quote from her as well, from Kaylin Paltrow, is about how different needs look, right? What are the varying needs that are occurring for each person, and how does a person fit in with this? The major criteria for ADHD, so here we have criteria A, persistent pattern, inattention, and or hyperactivity, impulsivity, that interferes with functioning or development characterized by one of the two. So inattention criteria is 6 or more of the following symptoms have persisted for at least 6 months to a degree that is consistent with developmental level that negatively impacts directly on social and academic occupational activities. Criteria 2 is hyperactivity and impulsivity, 6 or more of the following symptoms that have persisted for at least 6 months to a degree that is inconsistent with developmental level and negatively impacts directly or socially academic occupational activities. So criteria A through I for inattention, as seen before, there's meeting 6 or more of these in criteria um, with inattention, and there's this like the subsection of inattention. So this is very broad. I encourage you, and I will ask you to go into your DSM and review the criteria alongside with me and seeing what is actually written. I have the notes here, but it was just a little bit too long to fit on this slide. So go ahead and read your book for this specific criteria, but I'm going to go ahead and read the kind of shortened version here. Criteria A for inattention, fails to give close attention to detail. This may look like careless mistakes, missing details, work is inaccurate. Criteria B, difficulty sustaining attention to tasks. They often has difficulty remaining focused during a lecture, conversation, or lengthy reading. Um, Criteria C, does not seem to listen when spoken to directly. The person may seem elsewhere, daydreaming, absent, obvious distraction. Criteria D is often does not follow through on instructions. With this could be, it's written in the DSM as school tasks, chores, duties in the workplace. This may look like quickly losing focus, easily sidetracked. Criteria E often has difficulty organizing the tasks. This may look like subsequential or sequential tasks, like in order. May keeping materials belonging in order, messy, disorganized work, has poor time management, fails to meet the deadlines. For criteria G, we have, F. Often avoids, disliked, or reluctant to engage in tasks that are sustain substantial mental effort. So schoolwork, homework, preparing for reports, completing forms, often loses things necessary for tasks or activities. Schools, material, pencils, tools, wallet, keys, papers, glasses, things like that. Criteria H is often easily distracted by extraneous stimuli, and here we have a lot of different ones that we've talked about that utilize the distraction piece, but it's getting more specific because it's describing inattention, right? So easily distracted by stimuli for older adolescents and adults may include unrelated thoughts, so having thoughts that just don't relate to the conversation at all. Criteria I, often forgetful in daily activities, so doing chores, running errands. For older adults, returning phone calls, paying bills, keeping appointments. So this could be significant to how a person operates and maintaining function, because there's a lot of aspects that are needed, and provide insight to the daily tasks that are difficult for an individual who maybe experiences an attention ADHD type. So here we have hyperactivity impulsivity. Again, this is the subsection of the few sections ago that we talked about. I believe that it was 6 or more of these to be met for the criteria. So criteria A, again, this is the shortened version. Please follow along with your DSM. So noting, the symptoms are not solely manifestation of oppositional defiance disorder. This is the differential diagnosis that's noted in DSM. Defiance, hostility, or failure to understand tasks or instructions. Older adolescents and adults, at least 5 symptoms are required. So ODD is not the only aspect of the diagnosis, or like it could be ODD instead, something like that. Often fidgets. So criteria A, often fidgets with or taps their hands or feet, squirms in the seat. Often leaves seat in situations where they're expected to be seating. So they're walking around during class, something like that, or leaving their office chair in the workplace. The criteria C, often runs about or climbs in situations where it's inappropriate. For adults and adolescents, this may be not as present because someone is, as a child, you may just play more often, versus an adult, maybe feeling restless rather than actually running around because of that social component that may be possible, or um, interest. Criteria D, often are unable to play or take part in leisure activities quietly. Leisure activities for an adult, playing more for children. Criteria E, this often on the go, acting as being driven by a motor. That may be one of the questions that you hear when being very briefly um, screened for ADHD. That's not, to say that it's an official diagnosis, just being asked that question. Um, but that may be what you hear. They may be unable to or is unable to be or uncomfortable being still for extended time, like restaurants, meetings, or experience other restlessness, difficult to keep up with. Criteria F, a person may talk excessively. Oh, and then criteria G goes into the impulsivity aspect. So this person may often blurt out answers before the question is actually completed, and they may just finish the thought and then go into the next portion. So they're just blurting out the next portion. Criteria H often has trouble waiting their turn, like in line or playing with other children. Criteria I often interrupts or intrudes others. They may butt into the conversation, goes into that interruption again. They may start using other people's things without asking or receiving permission. And then for adults, this may look like intruding into others um, or take over what they're doing. So here we have some major criteria. This is specifications. These are going to be the things that just give you more insight to detail what is a client experiencing. So specifications, combination of presentation. If there's enough symptoms for both criteria, um, you may have for the past 6 months, there may be a combined presentation. Predominantly inattentive, presentness, if enough symptoms of inattention but not hyperactivity and impulsivity were present for the past 6 months. Predominantly hyperactive, right, again, for the past 6 months. Specifications in partial remission, when full criteria were previously met, fewer than the full criteria have been met for the past 6 months, and symptoms still result in impairment in social, academic, occupational functioning. Specify the severity. So here we have mild experience, where few of any symptoms is access to the required to meet diagnosis were present, and symptoms result if no more than minor impairments in social occupational functioning. Moderate symptoms to severe symptoms. So moderate's going to look like mild presentation, whereas severe may cause significant impairment for that individual. Again, there's this sense of somebody may have difficulty paying their bills or keeping up with their appointments. And that's kind of where the functioning comes in, and why it's important to notice the criteria being met um, for the diagnosis, so that way there's clear understanding of, hey, this is not this person's fault, right? Um, some people, when they experience ADHD or autism, um, I've heard individuals be called lazy, and that is incorrect, right? We're seeing here the different qualifications of, okay, this meets criteria for this diagnosis, and this is how we're getting into a little bit. How can a person be supported, and how can a person learn about the diagnoses to, um, be empowered to understand what's going on with them? So here I put in the difference, like DSM-4 to DSM-5. Um, often difficulty sustaining attention, this is criteria B for ADHD. So often has difficulty sustaining attention in task or play activity, versus DSM-5, which is often has difficulty sustaining attention in task or play activities. And here gives an example: difficulty remaining focused during lectures, conversation, or lengthy reading. So I see more insight and um, examples. Often does not seem to listen when spoken to directly. So here we're having more insight on what this could look like. Here I included an image. This might be a little difficult to see, so I encourage you to zoom in if you need to. Here we have, or do like a screen grab and be able to zoom in there. The Misdiagnosis Monday, this is a website where things are overlapped and compared, and I find these interesting way to have a conversation about it. So some um, criteria that's maybe in ADHD and not in autism, maybe seeking novelty, attention regulation, inattentive social cue challenges, whereas person with autism may seek familiarity, they may have bottom-up processing, um, and they may have attention locks deeply into one interest or task at a time, whereas both may have eye contact differences, special interest, sensory divergent, emotional dysregulation, and those are just to name a few, right? I'm curious if you made a graph like this, what comes to mind for you and how you would organize this, right? This is somebody's interpretation of it, and this is just to get us to think about, okay, what are the differences here? What um, what would you put in the overlapping perspective? Do you agree with most of these or disagree? Um, all right. So these next few slides, we're going to be talking about the assessments for autism. Now, as a clinician, you can't diagnose autism, and even when you have extra training to be able to do ADOS assessments, which is ADOS, those are not criteria to meet, a diagnosis. And we have to be very clear about that because it's pretty extensive. It's about an hour to 2 hours of their day. It's a 20-page report, and it includes grading and stuff like that. So even that's not a diagnosis. Why is that? The reason being is because, as you notice in the criteria, there's a lot of subjective aspects happening. Social reciprocity, repetitive behaviors. You're seeing, it may be subjective. So for one person to say, yes, this person meets criteria for autism, another person may disagree. And that does happen sometimes. So here we have assessments here listed. There's 3 right here that I pointed out. The next slide will have more, but this one has different age ranges. So we have ages 16 to 30 months, ages 12 to 60 months, and then ages 16 to 16 years and up. So this is going to be screening and saying, do we have a general idea? Are we maybe on the right track? Do we need to refer to get, maybe more investment needed into, does this person have autism? Are they experiencing this? Maybe this can help. So again, I have some repeated from the last slide, but what's important to notice here is that there are all kinds of different types of assessments that are screening for autism. What I'm noticing, the important part is going to be that language need and the age, because things are going to be represented differently if somebody has high interest in something or social reciprocity. Is that actually developmentally appropriate, or is that something that meets criteria for autism? Um, so these are all the different ones that I've seen, and there's some that are self-assessment, some that can be used to ask questions from themselves or from the caregiver. There's also a caregiver one, I think, specifically. Um, yeah, so these are all the different ones that if you come across and you're like, this person may meet criteria, or the client themselves or have, um, seen the criteria, because criteria for DSM is also online. It might be relevant to start to discover that with the client through these self-assessments, and then have a committed referral and be able to process that. So here I'm going to talk about ADOS assessment. So the version is version 2, and there's different types of ADOS, ADOS assessments. And they have modules Modules 1 and 2 are more for children. Modules 3 and 4 are more for adults. And there's also a language criteria. So someone comes in and they say, hey, I have, high functioning language, and I'm learning while I'm talking to them in the first couple minutes. Okay, maybe I need a different module, so it's able to be switched. There's also something called the MIGDAS, MIGDAS, um, and that is more utilized for underrepresented genders, mostly seen used with women and girls, because there's different types of criteria, and the ADOS was tested against and for mainly young boys who are white. So here we have some of the criteria. So this is an example of what a task may look like. This criteria on the right-hand side is just an image of what you see here, different things that are included. These are all different tasks here. The radio on the bottom right and like the toys are going to be used more during the break. The top left is probably going to be imaginative play. There's different types of activities, probably about 12 if I'm remembering off the top of my head. But here's an example of a task. So you have, this is real small. It's not meant for you to, fully memorize. This is just an example to gain insight on what does an assessment look like as a clinician who can screen for autism more extensively and support that diagnosis. And I did have extra training for this as well. So a demonstration task, you're going to ask the client to brush their teeth, and you're going to say, show me how you brush your teeth, and tell me how to do that if I never knew how to do that before. Description of a picture, you're going to be looking for the different, it's just an image, like a cartoon image of people having dinner, and you're just going to take note. What kind of things do they talk about? What brings their interest? How do they hold that conversation? So here we have the pamphlet of the ADOS assessment that I want to share with you all because I've done ADOS assessments at my job, and didn't really plan on doing it, but they had the opportunity to train. They had a grant to get a certain number of people trained and signed up and loved it. So yeah, it's really, really cool stuff to be able to support people in their journey and be able to learn more about it. But anyhow, so after doing the set of tasks that take about an hour to 2 hours, which is that last slide, I'm going to go through and I'm going to read all the criteria and I'm going to grade the experience. So some experiences are going to be, a certain number of times, and some questions, criteria are going to be, did this happen at all? And that's kind of how it's looked at. So, for example here, and please don't strain your eyes. This is not meant to be memorized, but just of interest for individuals that are, and be able just to gain some insight on what's going on. Anyhow, so if the person is asking for information, you can read that criteria there. But for example, a person would score 0 if they ask the examiner about their thoughts, feelings, experiences, or on several occasions, and that's reciprocal experience. Question or score of 3, rarely or never expresses interest in the examiner's thoughts, feelings, or experiences. And then for eye contact, that one is clearly on the DSM. We have a person may have appropriate eye contact or uses poorly modulated eye contact. So the scoring goes more into it in the training, of course, and just gotta say it. This isn't a training for ADOS assessments. You can't just go out there and do them because I'm showing you an aspect of them, of course. But yeah, so then once you go through, as you see on the right-hand side, you have the scoring FX. So this is just the specific questions that are actually pulled, and you just write down directly, did this score a 2 or a 3 or a 1 or a 0? Some questions are like an 8 if they don't apply. And all questions that are scored as 3 get scored actually to a 2. All right, and then you have like the final score. You add those up. You have the social affect area on the top, and then in the bottom on the right hand side of that image, the restricted repetitive behaviors. All right, So this middle image here, you have the different ages. In this specific module, I believe it's module 3, um, this would be converted for their age range and compare their results to children their age as well. So for example, if somebody scored, not sure if you could see my mouse or not. Let's see if I could point. Yeah, there we go. Um, if somebody scored, if they were 2 years old and they scored a 0, then their actual score would be a score 1. And that's kind of what that looks like here. So if you're scored as like an 18 and you're 20 years old, then your actual score would be score 10. And the criteria for autism is going to be, I believe it's 8 to 10 in that age range. Some people meet the cutoff and they need to get reassessed, so that does happen as well. Here we have assessments for ADHD. So this is just a screen grab of different types of assessments you're going to be seeing. Some assessments are going to be more extensive, where they're actually going through and testing for, like, there's various different criteria to meet, which could be testing for hearing, testing for different occupational needs, things like that, that go into it. But as a clinician, you're typically going to be seeing these screening tools, and this is where it gets into utilizing the community and really gathering support and insight with and collaborating with people. So here you have this one here, the Vanderbilt scale for ADHD. This one is going to be about 40 to 50 questions, and there's separate assessments for the teachers and the parents. There's different types. There's a lot of questions on there, so I encourage to get the one that looks a little bit easier to read and score for themselves, because some are like, oh, that line is very, very close. So um, this is where treating ADHD and assessing for ADHD is really going to be collaborating with community. Um, yeah. So here you have the other types. So you have the preschool scale, you have the SNAP. This one is for, ages 6 to 18 years old. This one is going to be for adults. Um, so these are going to be the main ones that I typically see being used. And the Vanderbilt is really awesome because it gains multiple insights on how much a level of a function this is actually going to be affecting the student or the client. All right, so the different types of treatment that you're going to be seeing is going to be mainly behavioral therapies recommended. You're going to have the surrounding support, which we'll go over a little bit, that can apply to both autism and ADHD. CBT is seen as useful for challenging negative self-belief, managing time, coping with dysregulation, which I find for DBT can also be very helpful in distress tolerance. For children, you're going to see play interventions, awareness of self and others, and regulation. So for example, utilizing the green, yellow, red game to be able to have awareness of self and others, and practicing self-control in a way that it's non-judgmental and there's not a lot of risk at play. So that may be why, awareness of self is going to be important to be able to understand those cues, because there may be the disconnect happening. Types of therapy recommended for autism spectrum disorder. What you're going to be seeing is ABA therapy provides skills, reduces harmful actions. There's conversation about this not being ideal. However, if somebody is having a really hard time or is classified as level 3 and there's a lot of difficulty for the client, this may be useful to build up some skills to be able to promote some sense of autonomy, some sense of self for the client or with the client. Speech and language therapy is very common, and so therapy, and it's utilized, throughout more than throughout and beyond, not more, but beyond mental health. So just keeping that in mind when talking about therapy with clients. Um, Occupational therapy, and that's different types of living skills that can be really helpful for people to have, even if they're living with a person or with an adult or family member rather, for longer periods of time. Um, they're still maybe able to cook or um, living by themselves, things like that. And as we see with like level one, there's lots of skills that people have, whether that's with occupational therapy or just with their um, development. Um, yeah, so these are important to consider. For a mental health therapist, you may be working alongside with somebody if they're in ABA to support more of the general needs. Um, if someone comes to you and you're not sure, there are still a lot of things that we can do as mental health therapists that even if you're not specifically qualified to work with somebody in, social skills, occupational skills, um, or self-regulation skills, there's still a lot of skills that can be applied, which are, to focus on the co-occurring disorders, OCD, anxiety, depression, supporting the client in processing and learning about ASD. So as I showed you all the assessment that I did, the ADOS assessment, we would give that, the assessment to them, say, hey, this is not an official diagnosis. Take it to your primary care, and if you so wish, you could share it with your school, you could share it with your current therapist, if you meet the criteria and if you receive the diagnosis, then it can be helpful in other areas of your life, such as therapy. So, what happens when your client comes to you and says, hey, I have this official diagnosis of autism now? How does that shift your work with them, even if you've been working with them for a while? Um, so, it could be in supporting them and exploring it because there's a lot of recommendations to go through and read different experiences or I'm sorry, read or learn about what is autism, like on their own time, because there's only so much time that can be given with that assessment. There may be an identity shift for individuals, especially if they're diagnosed in adulthood. Um, and you may utilize more direct communication. Medications for autism spectrum disorder, they're more for the symptoms. There's not an ASD medication like there's known ADHD medications. So example, SSRI is going to be helpful or might be helpful for repetitive behaviors, anxiety, irritability, I think I'm going to say that wrong. Tricylic? Mm, antidepressant, and it's used mainly for depression and OCD. Antipsychotic just medications can be helpful for reducing irritability. Stimulants can be helpful with hyperactivity. Anti-anxiety medications, and then anticonvulsant medications are often seen for people with autism because of the common experiences. About 1/3 of ASD individuals experience seizures. So you have medications for ADHD. You have stimulant and non-stimulant medications. There's significantly more stimulant medications as you can see here on the left-hand side. Here on the left side, we have the stimulant medications. I just did a screen grab, and this isn't the entire table, so I encourage you to go to it and maybe type up the title because the link was giving me a problem when I went back to it. But I pulled specifically the number of hours that this can be administered. So, for example, it looks like Ditrana, it can be given 6 to 16 hours. Dexedrine, I don't know how to say these fully, but 3 to 5 hours. So that means this person's gonna be taking this 4 times a day versus maybe this one is taking this every twice a day. This one can be once a day. Um, so it could be important, given, so, and then these are the non-stimulant medications, um, which, yeah, I mean, these could be given really young. So having continued conversations, if someone is on a stimulant medication, to have, I know it's recommended in my area at least to have conversations with the client or with the parent to have continuous levels checked For what exactly, I'm not sure. But it's important to have blood work done and checking on physical health when having these medications, because there's different risks alongside with them. But noticing if someone is taking medication 3 to 4 times in a day, but they're also experiencing difficulty with maintaining a schedule, that can be a really significant portion of maintaining safety with an individual. And that's important to consider when working with somebody who has medications at all, but especially with ADHD because of that schedule piece and getting distracted. Um, some stimulant-related side effects may be loss of appetite. I just have that here in my notes, so it's not here on the slide. But loss of appetite, difficulty falling asleep, dizziness, more irritability, growth problems, heart problems, and that's probably why the levels are important because of the heart problems are significant. Um, yeah, so keeping an eye and just being able to be aware of what's going on. You don't need to, go through and study every single one of these, but being aware of these are important when working with someone with this diagnosis. All right, so here we have the different treatments surrounding support again. A basic recommendation is going to be for both autism and for ADHD is going to be collaborating with the schools, with the clinicians. If you're somebody who goes into the schools, you can collaborate and be on those meetings as well. With telehealth, it's a lot easier to be able to jump on these calls and be able to support your client and having this well-rounded care. So a 504 plan is going to be getting more breaks, going to be more behavioral aspect. IEP is going to be more of how things are actually taught. So this may be considering if someone has also a learning diagnosis alongside with ADHD or autism, and considering changing the way that the material is actually taught. And that's an important distinction to know because there's different types of needs and different criteria for 504 and IEP. You're also going to be seeing different medications for ADHD specifically, and then for autism, it may be trying to maintain the symptoms, not necessarily an autism medication that doesn't exist. It's more about managing the symptoms. Behavioral management, and then psychoeducation, understanding why what's going on. This could be for the self, for the parent, for other loved ones around. Um, Collaborating, cross-discipline approach, understanding that there may be contact with the teachers, there may be contact with the parents, maybe contact with the medical provider to support client in navigating these things. Self-esteem also is co-occurring experience for a lot of individuals because someone doesn't feel like they're living up to their full potential because they feel distracted, because they can't meet these executive functioning happening sometimes. Yeah, and then the co-occurring disorders that are also present to be treated as well. So again, here we have the IEP, the 504 plan. Here's just a quick screen grab of the IEP and the 504 plan. Here you have the IEP, again, is how it's taught. And this is from the IDEA 1975. These are special rights laws. These are annual goals and progressive reports. These have specific qualifications. There's like a set diagnoses that are actually going to be qualified for IEP. Whereas the 504 plan, it's from the Rehabilitation Act of 1973 Civil Rights Law, and this has substantial limitations, whereas someone has substantial limitations and disability. Okay. So here we have accommodations recommended from the 504 for a 504 with somebody with autism. So this may look like providing predictable routines with visual schedules, give advance notice of changes, allowing sensory breaks, providing noise canceling headphones, offering reduced recommended during sensory overload, reduced demands, excuse me. For ADHD, this is just a screen grab again of recommendations for 504 plan, which are providing supervision during transition, engaging student in passions, provide a hook when teaching a lesson, reinforcing appropriate behavior, allowing the student to run errands or stand at times while working, sitting the student away from distractions, and establishing a school at home behavioral management plan. All right. So these are just examples of the ways that well-rounded support is going to be so necessary for someone with autism or with ADHD. So here I have some history. We have ADHD or ADD to ADHD. So you may have heard that and say, where does that come from, right? And so, for example, ADD was in the DSM-3, the specifications with or without hyperactivity. So just the way you see specifications for diagnosis, this was the classification. And then in 1987, ADHD was termed, and then ADD was discontinued in 1994. So there are, with the history of these types of diagnosis, you may notice the development of changes that are happening in DSM, and the reason why it's important to engage with it as professionals, because any person, could be part of this story to add to the DSM, to add, critique and add to it. That's just a side note, but ADHD now talks about the hyperactivity and deficit with the hyperactive or impulsive subtypes. All right, so here we have a continued understanding and history of how autism has been understood, defined, and the different words that have been used to describe these set of symptoms. So this is interesting, right? The history, this is of course outdated, right? That's why I have it in quotations. Mental retardation established 1828, and now the criteria for that would be classified as level 3, because the spectrum really speaks to the varying experiences that a person has. Autism by Eugene Bueller. This is not, going to be on the test or anything. This is just to get an idea of what was going on. How did we get here? Anyhow, so this is in 1857. This was a person who was described as who had schizophrenia and who were withdrawn. Autism or disturbance of affect contact. This was a paper published in 1943. This is describing somebody who has difficulty social interactions, good memory, sensory stimuli. So noticing that these, that might have met criteria, or at some level describes of what we see today, but there's different context. Here you have the early infantile autism, autistic psychopathy, childhood schizophrenia. Childhood is an interesting use, and so schizophrenia here, and then you have schizophrenia here. So there is that connection there, because it's describing somebody who has a social withdrawal, and this was in the DSM-1 and the DSM-2, latest seen, in DSMs in 1968. Then you have in 1980 infantile autism. Asperger's syndrome is maybe what you hear the most with outdated terms, and that is, I believe 2014 is that last time that we see it. And then first it was first included into the ISD-10, which I believe is for billing and to be considered an actual diagnosis in 1993. Autism disorder seen in DSM-3, revised in DSM-3, first seen in 1987. Pervasive developmental disorder is in 1994, DSM-4, for an umbrella term to be able to capture various developmental disorders. DSM-5, we see autism spectrum disorder in about 2013, and it's noted from one of the readings that I had which is that the diagnosis that you see in previous terms is maybe would not, so somebody who's diagnosed today, an adult, may not have met criteria back before, what, 2014 or, yeah, about 2014, 2013, it looks like, um, would not have met criteria for autism because of the broadening, right, the spectrum that we see. Asperger's and high functioning, um, this is seen as outdated as well by many folk because it does not describe that there are difficulties, but also like a lived experience for people, right? So high functioning should, encourage to avoid using that term the same way that we avoid using retardation. And that's because there's better ways of explaining what we mean and collaborating with individuals, asking, what's understood, what's necessary. So rather being able to understand the different levels or different support that a person actually needs. And this is not to label a person to say, this person always needs support with X, Y, or Z. This may look different from day to day, right? And understanding a person's needs over time. All right, for adult diagnosis, how does this happen? How does a adult diagnosis happen? Are there more adults diagnosed with autism than before? No, the change does not happen over time. There's not been a significant. Rather, it's more about the criteria and the awareness that we're seeing. So there's more awareness. There's more screening happening for ADHD. I can't speak to the other fields, but to my understanding, there's more people being trained in it, such as teachers, pediatricians, primary care, that can also screen for autism to be able to point people in the right direction. Now, there's hereditary components that we've seen with ADHD and with autism. So if you have an experience as an adult, and I say you as in a general person, so if a person um, goes in and has their child assessed and they're learning about, okay, what is ADHD or what is autism? And, oh, this kind of sounds like me. That sounds like me when I was growing up. Um, or, you know what, me and my kiddo, we act totally the same. And then the assessments come back, yeah, we are testing, um, and you are meeting criteria for autism. So this made me see where, okay, now the adult chooses to get assessed as well. There was once where I had an entire family. I was part of like a team who was assessing this whole family. They didn't have a car, and so they took the bus, and it was the mom, the dad, and three children who were all getting assessed in the same day over a various amount of hours. And they weren't all, scheduled the exact same time. So they had spent quite a long day at the office and was able to get the bus home. But yeah, there's a lot of experiences with families who are able to um, gain insight from more awareness of what autism spectrum disorder means. And for many people, there might be an experience of relief for people to understand their experiences over time, to be able to understand, and this is just evidence from working with individuals and hearing their stories of getting diagnosed as adults, to be able to understand themselves, even if they didn't have children and they wanted to get diagnosed just for their own experience. So here I have different identities that are related to autism. Um, and here I want to go over this first, which is I am autistic versus I have autism. This is going to be a difference that you'd have to ask each person to be able to understand what that person wants, right? Oftentimes we hear the language to not say that a person has depression, that they're dealing with depression, right? But that is something where depression symptoms can be subsided, can be resolved, versus autism, saying I have autism. To some individuals, that can imply that that the symptoms can subside, versus being able to identify with the diagnosis to say I am autistic, um, then that becomes part of the experience for that individual to be able to identify and um, maybe even relearning themselves as the individual, or their identity as somebody who is autistic. So it just depends, but that is part of the background and language of why you may hear that discourse. Moving on to more section of identity. Um, is trans people are 3 to 6 times more likely to be autistic. One study found that genderqueerness was significantly more common among autistic people. And so here it's even describing someone as autistics, and I'm saying autistic people. And so vernacular, my typical way of describing something is saying people with something. And so that may be just a change for myself as well. But going back, we have genderqueer is significantly more common in people with ADHD compared to an autism, compared to general population. The prevalence of LGBT identities is 2 to 3 times higher among people with autism, and autistic men being more likely to be heterosexual than autistic women. Other studies found that ADHD people were more likely to identify as non-heterosexual than non-ADHD people, or people without the diagnosis. All right. Here I have vulnerabilities for people with ADHD and autism. This is where the conversation comes into how is it that, um, or maybe even disappointed in media, news, or movies, when someone is sort of blaming criminal behavior on a um, mental health diagnosis, whereas we're seeing that there's more likely to be victimizations rather than criminal behaviors. So for example, for ADHD person, peer victimization, there's a correlation happening. For autistic women and genderqueer individuals are more likely to be survivors of violent victimization. So the reason why this may happen is because of missing social cues related to manipulation. That self-protection piece, it's really difficult to see that. Um, that vulnerability piece, because it's difficult to assess, if that's happening in the moment for people. Autistic adults were 7.3 times more likely to report having experiences of sexual assault from a peer as a teenager as well.